40%. I mean, that is just a staggering number.
It really is.
Yeah, 40% of people, when they're handed a medical diagram, they literally cannot correctly point to the structures of their own genital anatomy.
Right, which is wild.
Exactly.
Right.
We live in this era of, hyperinformation. You can look up the exact coordinates of a satellite in orbit on your phone. But when it comes to the human vulva, almost half of us are just operating completely in the dark.
Yeah, and it highlights this massive blind spot in how we're taught to understand our own biology. I mean, we monitor our faces for new freckles, right?
Sure.
Or our hands for tiny paper cuts.
Yeah, constantly.
But this entire region is just treated as like a void.
Well, today we are turning the lights on in that room, so welcome to the deep dive. Our mission today is to demystify a really specific but fundamentally important health practice, and that is how to perform a comprehensive vulvar self-examination.
Which is so crucial.
It is. And we're looking at this specifically through the lens of monitoring a chronic skin condition called lichen sclerosus, or LS.
And to do this, we're pulling from a really rigorous stack of sources. So we've got the clinical guidelines from the British Association of Dermatologists, practical diagnostic guides from the Vulval Pain Society, and the UK Lichen Planus Group.
Right. A lot of heavy hitters.
Yeah, alongside patient information leaflets that are synthesized from various NHS trusts. So it's a very solid foundation.
It really is. And if you are listening to this, I just want to talk directly to you for a second. We know that talking about intimate anatomy, it carries a lot of cultural baggage.
Oh, absolutely.
Like it feels taboo, right?
Yeah.
But knowledge is absolute power. So whether you're currently dealing with unexplained vulvar pain or persistent itching, or maybe you already have an LS diagnosis, or you just want to be a fiercer, more informed advocate for your own body.
Whichever one should be.
Exactly. This deep dive is your roadmap. We're going to give you the practical, step-by-step mechanics to basically take control of your health.
But before we get into the actual mechanics of the exam, we really have to define the condition we're looking for, right? So lichen sclerosus, it's a chronic inflammatory skin condition.
Okay.
And first, let's just clear up the common misconceptions. It is not an infection. It is not contagious, meaning you cannot pass it to a partner.
That's a huge relief for a lot of people, I'm sure.
Definitely. And crucially, it does not extend inside the vaginal canal or inside the anus. It strictly affects the surface skin of the vulva and the skin surrounding the anal region.
Got it. Now, looking at the symptoms described in the clinical data, I have to say they sound agonizing.
They can be, yeah.
Because the primary complaint is this severe itching, which the data shows typically spikes at night,
Right.
Just completely destroying a person's sleep cycle. But then you also have these intense visual and structural changes, like the skin turns white and shiny.
Almost looking like porcelain.
Right. And it becomes incredibly fragile. I noticed the medical literature often uses this specific phrase. They call it cigarette paper.
Yeah, that's exactly how they describe the texture of the skin in advanced or untreated stages. It becomes crinkled and translucent, and it's so fragile that it's prone to tearing with even the slightest friction.
See, I really want to understand the mechanism there. Like, why does the skin take on that specific cigarette paper texture? What's actually happening beneath the surface?
So it really comes down to the destruction of collagen and structural proteins in the dermis. Lichen sclerosus is generally understood to be an autoimmune condition.
Okay, so like a hypervigilant security system.
Yes, great analogy. Your immune system basically sends inflammatory cells to the vulvar skin, and these cells, they misfire. They attack the healthy tissue and break down the elastin and the collagen.
And those are the things that give skin its normal thickness and stretch, right?
Exactly. So as those proteins are destroyed, the skin thins out dramatically and it loses its blood supply. And that's what causes that white blanched appearance. And it makes it highly susceptible to, splitting or bruising.
So the chronic inflammation is literally just dissolving the structural integrity of the skin.
Precisely. The barrier is compromised at a cellular level.
Wow. Okay, that actually brings up a major point of confusion for me when I was reading the guidelines from the British Association of Dermatologists.
Oh.
Yeah, so they recommend that a patient with a confirmed LS diagnosis get a checkup with a doctor once a year. But then the NHS leaflets, they tell you to get a mirror and examine yourself every single month.
Right.
So if a specialist only needs to see you annually, why should you put yourself through the anxiety of scrutinizing your own skin every 30 days? It seems contradictory.
I get that. It seems contradictory at first, but 12 months is a massive window when you're dealing with a dynamic inflammatory response.
Oh, okay.
The yearly checkup is for a high-level clinical review and prescription management. But the monthly self-exam, that's about catching rapid architectural changes and mitigating a very specific, serious risk.
Okay, wait. When the sources talk about architectural changes, what does that actually look like in practice?
Well, because the inflammation breaks down the skin's protective layers, the raw tissues can actually begin to heal together in ways they shouldn't.
Oh, wow.
Yeah. Think of it like a zipper on a jacket that's been left out in the rain for months. The metal rusts, and eventually the two sides fuse completely solid.
That is a terrifying visual.
It's serious. With LS, chronic low-level inflammation acts like that rust. So over a matter of months, the inner labia can flatten out and fuse to the outer labia.
Right.
The delicate hood of skin protecting the clitoris can fuse shut, basically burying it,
Hmm.
and the entrance to the vagina can severely narrow.
I mean, that sounds like it would cause immense pain, not to mention the functional issues and the psychological impact.
It does. It absolutely does. And beyond the fusion, there is also the risk of malignancy.
Right, the cancer risk.
Yeah, the sources note a small risk, less than 5%, but it's very real of lichen sclerosus developing into squamous cell carcinoma, which is a type of vulvar cancer.
Less than 5%, but still you want to be ahead of that.
Exactly. So if you are checking monthly, you become intimately familiar with your baseline. You're going to spot a precancerous lesion or the beginning of that rusted zipper fusion long before your yearly appointment.
And catching it early means you can apply a topical steroid to stop the inflammation before the fusion becomes permanent.
That's the whole point. You intervene while the damage is still reversible.
Okay, that makes the monthly check make total sense, but we circle right back to that jarring 40% statistic we started with.
Yes.
You cannot monitor your body for architectural changes if you don't actually know what the architecture is supposed to look like in the first place.
Exactly. The inability to identify one's own anatomy creates a massive barrier to medical care.
Right.
Like, if you experience a tearing sensation, but you literally don't have the vocabulary to tell your doctor whether it's happening at the perineum or the vestibule, shared decision-making completely breaks down.
And I think a huge part of why people don't know their anatomy is because they are terrified that what they look like isn't normal.
Oh, absolutely. The stigma is huge.
Right. And the sources actually address this anxiety head on. The medical literature references this art installation by the sculptor Jamie McCartney called The Great Wall of Vagina. Have you seen the background on this?
I have, yeah. The project with the plaster casts. It's heavily cited in discussions about genital cosmetic surgery, actually.
Yes. So he took highly detailed plaster casts of the vulvas of 400 different women and just displayed them side by side.
It's incredible.
It really is.
Yeah.
And the medical community actively points patients to this project, along with resources from the Royal College of Obstetricians and Gynecologists, to demonstrate that labial size, shape, color, and symmetry vary wildly.
Because they do.
Right, like some are tucked in, some protrude, some are totally asymmetrical. Normal is not this standardized airbrushed image. Normal is just a massive, chaotic spectrum.
And deprogramming that expectation of a perfect aesthetic, that is the required first step. Because once you accept that your baseline is just uniquely yours, learning the map becomes an objective exercise rather than, a judgmental one.
So let's map it out for our listeners. The Vulval Pain Society provides a really clear anatomical breakdown. So if someone is looking in a mirror, where do we start the tour?
Well, we start at the very top and move downward. So the uppermost area, which is situated over the pubic bone, is the mons pubis.
Okay,
This is the fleshy, fatty pad that is typically covered in pubic hair.
got it. And from the mons pubis, we move down to the outer lips.
Yes. Anatomically, these are known as the labia majora.
Right.
These are the larger outer folds of skin. And like the mons pubis, they contain fatty tissue and are usually covered in hair, so they act as the outermost physical barrier.
Okay, and then nestled just inside those outer folds.
That's where you find the labia minora, the inner lips. And this is where the tissue changes significantly.
Also.
Well, the inner lips do not have fat, and they don't grow hair. They are essentially specialized sensory tissue. And because they lack that thicker, keratinized protective layer of the outer skin, they are highly susceptible to the fusing we discussed earlier.
Okay, that makes sense. And if you follow those two inner lips all the way up to where they join together at the top, just under the mons pubis, That junction forms the clitoral hood, which covers the clitoris.
Correct. And then if you move just slightly down from the clitoris, staying between the inner lips, you will locate the urethra.
Right, which is the very small opening where urine exits the body.
Exactly. And continuing downward from the urethra, you arrive at the vestibule.
Which is the medical term for the actual entrance to the vagina.
Yes. And finally, if you continue past the vaginal opening, heading towards the back, you cross a bridge of skin and muscle called the perineum,
Okay.
and that connects the vaginal area to the anus, which completes the structural map.
Okay, that top-to-bottom progression is incredibly logical. But I have to ask about the reality of the doctor's office. Let's say you memorize this map right. You do the exam, and you find a white patch near the vestibule. Saying those words out loud to a clinician while sitting in a paper gown, I mean, that can be paralyzing for a lot of people.
The psychological barrier of vocalizing the taboo is very real. But the sources, specifically the UK Lichen Sclerosus Guide, they offer a brilliant workaround for this.
Really? What is it?
They provide printable anatomical diagrams and symptom checklists.
Oh, that's smart.
Yeah. The recommendation is to print the PDF, check the boxes for your symptoms, physically circle the area on the diagram where you see the change, and simply hand the paper to the doctor when they walk in the room.
So you completely bypass the need to speak. You just let the data do the talking.
It empowers the patient to communicate highly specific medical information without the hurdle of embarrassment.
I love that. Okay, so we know the geography and we know how to report the findings. How do we actually conduct this exam? The NHS guidelines lay out the logistics, and it requires more setup than just, glancing down in the shower.
Much more, yeah.
First, you need dedicated privacy, a locked door where you will not be interrupted. But the second requirement they emphasize is intense lighting.
Because a standard dim bathroom ceiling light is just insufficient. You are looking for subtle changes in pigmentation and texture.
Right.
So you need a bright, direct light source, whether that's natural sunlight from a window, a strong reading lamp, or even a specialized flashlight.
As for the physical positioning, the sources offer a few options. You can lie back on a bed propped up by pillows. You can stand and place one foot securely on the edge of a chair or the toilet. Or you can sit on the edge of a chair with your legs astride.
All good options.
And traditionally, you would use a good handheld mirror. But I found a highly specific modern adaptation in the literature from the British Society for the Study of Vulval Disease.
The selfie stick tip.
Yes. If contorting with a mirror is difficult, they actually suggest using your mobile phone attached to a selfie stick.
And honestly, the selfie stick adaptation is incredibly practical when you think about the optics.
Really? How so?
Well, a phone camera provides a different focal length than a mirror, so it can capture a wider, clearer field of view without you having to bend your spine awkwardly.
Well, that makes total sense.
Furthermore, the phone has a built-in, highly targeted flash, so you can view the real-time image on the screen comfortably, and it gives better illumination than trying to juggle a mirror and a flashlight simultaneously.
Okay, so you have your lighting, you're in a comfortable position, and you have your screen or your mirror. What is the actual physical technique?
Well, the most critical failure point in self-exams is treating it strictly as a visual test.
Oh, so it's not just looking.
No, you must look, but you also must feel. As you move geographically from the mons pubis down to the perineum, you have to actively use your fingers to separate the outer and inner lips.
Because if you just do a superficial visual sweep, you're only seeing the outermost barrier.
Precisely. Lichen sclerosus lesions, and particularly early precancerous cellular changes, they frequently initiate deep within the folds of the labia minora or under the clitoral hood.
So they hide.
Yes. You have to part the tissues gently, look into the crevices, and then use your fingertips to feel the entire surface area.
Okay, so what are the fingertips feeling for that the eye might miss?
Induration. That's a medical term for abnormal thickening or hardening of the tissue.
Okay, induration.
Because before a lesion changes color dramatically enough to catch your eye, it often changes the density of the tissue beneath it. So you're feeling for areas that feel leathery, maybe raised bumps, or a sudden loss of elasticity.
That actually transitions us perfectly into this AT checklist.
Mhm.
What are the definitive red flags that mean it is time to hand that marked up diagram to a doctor? I don't want to just run through a list. Let's talk about the visual journey of a flare-up.
Sure. So the first indicator is usually a shift in pigmentation. You're scanning for new areas of distinct porcelain white skin.
Okay.
However, the inverse is also a major red flag. New, dark, heavily pigmented freckles or moles that have appeared since your last check.
White or dark.
Mm.
Got it.
Exactly. From color, you assess texture. This is where your fingertips detect the induration we just discussed, or perhaps the sudden appearance of new warts or skin tags.
And if the skin barrier is already compromised by that lack of collagen, you are likely looking for active damage, right?
Yes. So the third major category of red flags involves structural breakdown. This manifests as open sores, ulcers, blisters, or deep cracks in the skin, often called fissures, that bleed easily and refuse to heal.
Ouch.
Right. And finally, you assess the architecture. Has the clitoris become less visible because the hood is tightening? Are the inner lips shrinking or beginning to adhere to the outer lips?
Now, a crucial boundary is heavily emphasized across the patient information leaflets, particularly from the specialized women's health clinics.
Right, the self-diagnosis warning.
Exactly. They explicitly state, do not attempt to self-diagnose based on your visual exam. But why is self-diagnosis so dangerous if we're actively encouraging people to look?
Because lichen sclerosus is a master mimic. The severe itching, the burning sensation, the redness that often accompanies a flare-up, these symptoms can perfectly replicate a severe yeast infection, commonly known as thrush.
Oh, wow.
Yeah, and they can also mimic vaginal atrophy caused by dropping estrogen levels during menopause.
So if a listener feels the itch, assumes it's thrush, and runs to the pharmacy for an over-the-counter antifungal cream, they could be losing critical time.
Exactly. The sources point out a common, dangerous trap. Patients treating themselves for thrush repeatedly over several months, while the underlying LS inflammation is causing permanent architectural fusion.
That is heartbreaking.
It is. So if you use an over-the-counter thrush treatment and it does not resolve the issue, that is a definitive signal to seek professional medical evaluation.
That leads directly into another critical safety boundary found in the NHS protocols. Let's call it the 2-week rule.
The 2-week rule is your safeguard against malignancy. If you have a confirmed LS diagnosis, you likely have a prescription for an ultra-potent topical steroid ointment to manage flare-ups.
Right.
If, during your monthly exam, you find a new skin change, a localized thickening, or an ulcer, you apply your prescribed treatment.
Okay. And then
If that specific lesion does not respond and begin to heal within 2 weeks, you must seek urgent medical advice.
so 2 weeks is the absolute limit. You don't wait to see if it gets better in a month.
No. 2 weeks is the clinical threshold to rule out squamous cell carcinoma. Do not wait.
With all of these subtle changes, pigmentation, texture, fusion, how is a listener supposed to remember exactly what their anatomy looked like 30 days ago? I mean, memory is notoriously unreliable.
It really is. And the Lichen Sclerosus Guide recommends adopting the mindset of a data scientist for your own body.
I love that.
Do not rely on memory. First, maintain a flare-up diary. Document your symptoms alongside environmental factors like what you were wearing, what activities you were doing, or if you were experiencing high stress when the itching spiked.
Okay.
Second, and this is where the mobile phone becomes invaluable again, take regular photographs during your monthly checks.
So you essentially build a longitudinal timestamp photo album of your baseline.
Exactly. Comparing a photograph taken today against one taken 3 months ago is the only truly objective way to determine if a steroid treatment is actively reducing the white plaques or if the architecture of the labia is slowly changing over time.
Before we wrap up, we really need to touch on the daily survival mechanics.
Yes, the day-to-day is so important.
Right, because beyond the monthly checks in the steroid ointments, the sources offer very specific everyday management strategies to protect that fragile skin barrier.
And the cornerstone of daily management is the liberal use of emollients.
Emollients, so medical moisturizers.
Exactly. And their function here is purely structural. Because the LS has compromised the skin's natural barrier, applying an emollient creates an exogenous protective lipid layer over the vulva.
Okay, so it acts like a shield.
Yes. This physical shield prevents highly acidic urine from coming into direct contact with the raw, thinned-out tissue, which prevents severe stinging and further irritation.
But there is a massive, incredibly serious safety warning attached to emollients in the BSSVD clinical flashcards.
Yes, there is. The most effective heavy-duty emollients are often paraffin-based.
And paraffin is flammable, right?
Highly flammable. It's essentially a combustible wax or oil. When you apply these creams daily, the paraffin transfers from your skin into the fabric of your underwear.
And what happens when it gets into the fabric?
The cotton fabric of your clothing acts exactly like the wick of a candle.
Oh my God.
It absorbs the paraffin, and if that saturated clothing comes into contact with a naked flame, A dropped cigarette, a space heater, or even just sitting too close to an open fire, it doesn't just burn, it accelerates the burn dramatically.
That is a terrifying side effect that people absolutely need to be aware of.
It's a severe fire hazard. You must be deeply cautious and wash clothing and bedding at high temperatures to strip the paraffin out.
Wow. Okay, so wash at high temps. The rest of the daily management advice is focused on basically minimizing microtraumas, right?
Yes, avoid tight clothing that causes friction.
Makes sense.
Never use traditional soaps or bubble baths, which strip away natural oils. You have to use soap substitutes instead. And after using the toilet, never wipe aggressively.
You just dab it.
Right, you simply dab the area gently to dry it. Every single action should be aimed at minimizing friction on tissue that is already struggling to hold itself together.
We have covered an immense amount of ground today. We moved from understanding the cellular destruction caused by lichen sclerosus to destigmatizing the anatomy with plaster casts, to mastering the selfie stick exam, and finally understanding the critical 2-week rule for ruling out cancer.
It's a lot, but the overarching theme here is that monitoring your own anatomy is not just a medical chore.
Right.
It is an act of profound self-advocacy. It arms you with the data required to bridge the communication gap with your healthcare provider, ensuring that your treatment is proactive rather than reactive.
I couldn't agree more. Taking 10 minutes a month to map your own body transforms a frightening diagnosis into something manageable. But to close this out, I want to leave our listener with something to consider beyond just their own bathroom mirror.
I think that's a great idea. Consider this. Historically, medical science often left patients completely in the dark about their own bodies.
Totally. It was all behind closed doors.
Exactly. They treated anatomical knowledge as something only a doctor was allowed to possess. It was a secret language. But by simply holding a mirror or, a selfie stick and learning the terrain of your own body, you are pushing back against a massive history of medical mystery.
You're taking the power back.
Precisely. It turns a scary diagnosis into an opportunity to finally meet, understand, and fiercely protect a part of yourself that has been ignored for far too long.